Okay, good morning. I hope all of you can hear me. Yesterday we had spoken about, we started on the CNS, and the most important topic was meningitis, which I told you that I will give you some chart interpretation to make it very clear to you what is absolutely necessary for you to understand about meningitis. Today's class, I will start first with just again a general knowledge about the CNS pathology, which is not very important as far as pathology questions are concerned. But the first 20 slides will be like that, but the rest 20 slides will be on the tumors of the CNS. And as and when I will be able to tell you what are the things which we expect from you in pathology. Okay? So the first topic slide which I have kept is these are just general knowledge. So just relax and just listen through. The cerebral edema means when there is accumulation of excess fluid within the brain parenchyma. So this picture here, there are two pictures. This is a picture in which you can beautifully see the sulci and the gyri. But here you can see that the brain looks a little bit enlarged, swollen up, and you cannot really appreciate the sulci and gyri properly because it seems to be merging and it's become smooth. So this is a sign that it is cerebral edema. These are all autopsy pictures. Then you have something which is known as herniation. This is what is important for you to understand about herniation clinically is that when there is a tumor in the brain, okay? So when there's a tumor in the brain, it occupies space. You can see that there's not much space in the brain. However, if there is a tumor in the brain and it's occupying space, it increases the intracranial pressure. So when the intracranial pressure is increased and we want to do a CSF analysis, so you have to do a lumbar puncture. So yesterday I showed you that lumbar puncture, before doing a lumbar puncture, we have to always measure the pressure of the CSF. If it is very high pressure, it is a contraindication to do a lumbar puncture because if you do a lumbar puncture and release the CSF, it will come very rapidly. And if the CSF comes very rapidly, the brain is already under pressure and you are releasing the pressure rapidly from the lumbar puncture site, then parts of the brain may herniate out. Okay, so these are not very common. Falcine and uncinate is not very common. But the tonsillar herniation is a known fact and it is the most dangerous because it presses on the midbrain and the patient goes into respiratory arrest immediately. Okay, so what you have to remember is when you do a lumbar puncture, always you have to know that the CSF pressure is normal. If the CSF pressure is very, very high, you anyway do a lumbar puncture, the CSF is going to shoot out and the pressure will come down rapidly, causing parts of the brain to herniate. The most dangerous is the tonsillar herniation because it presses on the midbrain and causes respiratory arrest on the table. Then hydrocephalus. This is, I think, I don't know whether you have seen babies with very, very huge heads. The next one is hydrocephalus, in which there is increase in the CSF volume. And this usually happens when the fontanelle has not yet closed. So there is space for the brain to expand. So you get ventricle cavities which are very huge and the whole head becomes really big. Now, this is something which cerebrovascular disease is something which you will encounter in your daily practice. And these are pathologic processes which involves blood vessels. As far as pathology is concerned, we don't ask you much questions on this. But as far as your clinical knowledge is concerned, cerebrovascular disease is quite a common disease, what we know commonly as stroke. So there are three basic processes behind this cerebrovascular disease. One is it could be a thrombotic occlusion of the vessel itself, or it could be an emboli, which has gone and occluded the vessels. This is a very common phenomenon, embolic occlusion of vessels. And it may be a vascular rupture. So you can see here, this is when there is thrombotic occlusion, there is a cerebral infarction, underlying cerebral infarction. You can see that the brain doesn't look normal. This is a normal part, and here this is infarction. These are also areas of infarction, and this is an area where there is hemorrhage. Then cerebral infarction on microscopy. Yesterday I showed you cells of the CNS. I was telling you that glial cells are astrocytes, oligodendrocytes, and ependymal cells. Apart from that, there are other cells which are microglial cells. So microglial cells are very tiny cells in the brain. You on HNE, it's you can just see a small blue dot. Otherwise, you cannot see the cytoplasmic processes. And these cells become very multiple when there is an infarction. So when the brain undergoes infarction, then this is a area of the brain in which the neurons are a little bit shrinky and red. That means there is some neuronal damage. Okay, so this is a sign of damage or trauma, whatever degeneration in the brain. So you have red neurons. And here you have an area, this is a blood vessel. You can see these RBCs are inside, this orange color. Surrounding that is the inflammatory cells, so there is perivascular inflammation. And there is also multiple blue dots in the brain. That means there is the cells are traveling from the vessels into the brain, reacting to something. And here you can make out that you cannot actually say whether this is a section from the CNS. What you can see is just multiple macrophages, and these are the blood vessels. So these are the microglial cells. When there is an infarction, there is sheets of these macrophages which are actually microglial cells. And this slide here, you can see the bottom half is blue. This is a special stain which is known as Luxel fast blue, which is a stain for myelin. So that can be an objective question for you. A stain for myelin is Luxel fast blue. Okay, so when we take a section from the brain and we stain it with Luxel fast blue, and as you can see in this section, part of it is blue, part of it is not blue. That means the part which is not blue has become demyelinated. So in demyelination also we may get areas which have sheets of microglia. So these are saccular aneurysms, which I know in anatomy you must have read. So I'm not going to go into details of it. You can just remember this, that there are some aneurysms, and these are dangerous because they can cause hemorrhage into the brain, and you can see that the brain gets replaced with hematoma because of the hemorrhage. These are intracranial hemorrhages, which may be subarachnoid. Subarachnoid means below the arachnoid, subarachnoid hemorrhage. It may be intracerebral hemorrhage, which may be due to vascular malformations like arteriovenous malformations. Now coming to trauma of the brain. Trauma to the brain, you know, anything to do with the brain and spinal cord, it can cause death, and worse, it may cause disability. And the severity and site of injury can affect the outcome. But you know very well, we have seen multiple movies in which these serial killers, they do a frontal lobectomy to change the way they, to reduce the aggressiveness. So if the frontal lobe is damaged, it is usually clinically silent. That's why you can actually do a frontal lobectomy in such people. And it seems that if you do a frontal lobectomy, the aggressiveness reduces, and that's how they treat the serial killers. I don't know whether it's really ethical or not, but maybe, I'm not so sure. Then if spinal cord, you know very well, at every level of the spinal cord, there is severely disabling symptoms. If it's at cervical level, there can be quadriplegics, or if it is a lumbar level, it may be hemiplegic, okay? Then if it involves the brainstem, just like what I showed you in that herniation, if it involves the brainstem, it is a rapidly fatal thing because it causes respiratory arrest. Now, this is again just to recapitulate the layers of the skull, the skin, the periosteum, the skull bone. Then these are the layers of the meninges, and this is the underlying brain. So you can see here that this is the space where the CSF is, and there are a lot of these green things. These are the arachnoid granulations and the arachnoid villi, which fill this, and they allow for friction in the brain along with the CSF. So again, there are hematomas in the brain. Epidural hematomas are usually between the skull and the dura mater. So it does not involve the brain at all. And this is usually because of an overlying skull fracture, which can lead to arterial bleeds, and there can be a hematoma here. So this is epidural, above the dura. And some accidents may lead to subdural hematomas, and subdural hematomas, as you can see in this picture, you can see these blue things. These are the veins, emissary veins, okay? And these emissary veins come inside. These are the superficial cerebral veins. So when there is severe trauma, these veins may get totally disrupted, thereby causing a hematoma filled with venous blood. And this is a subdural hematoma, meaning that it is below the dura and above the arachnoid. So you have the dura still attached to the skull. Now coming to an important part which, as far as pathology is concerned, tumors of the CNS. So this, I want you to listen to me very carefully. There are very few tumors which we actually ask questions about, but it is nice to know all this general knowledge about tumors of the CNS, and it's quite interesting also. So the annual incidence is 10 to 17 per lakh for intracranial tumors, 1 to 2 per lakh for intraspinal, and the rest are primary tumors. In old age, it's mostly metastatic tumors of the brains, and many children do suffer from CNS tumors. So there is a huge classification of CNS tumors which you do not need to know about, okay? But what you have to know about is that there are, remember I told you about glial cells, which are the supporting cells, and these are 3 types. There are astrocytes, oligodendrocytes, and ependymal cells. So astrocytes cause astrocytic tumors. Under that, there are so many, okay? I'll be telling you about it. Oligodendrocytes can cause oligodendroglial tumors, and ependymal cells can cause ependymal tumors. Okay, so these 3 you have to know: astrocytomas, oligodendrogliomas, and ependymomas. Okay, and another thing which is important for you to know is the tumors of the meninges. Meningioma. Meningioma, there are so many types pathologically, which it's okay if you don't know. If you know transitional meningioma, it's more than enough. And we do ask you short notes on meningiomas. But there are so many other tumors of the brain which we will not talk about now. So when it comes to glial tumors are known as gliomas. Okay, so glioma is a clinical term. When you take a biopsy of a glioma, as pathologists, we have to tell you whether that glioma is arising from the astrocyte, from the oligodendrocyte, or from the ependymal cells. Okay, so we have to give a grading, and we have to give a name to that tumor, whether it's an astrocytoma, or whether it's an oligodendroglioma, or is it an ependymoma. The thing is, when we say these different tumors, even though they come under the umbrella term of gliomas, each one has different prognostic gradings. So the clinical progression also differs. And most importantly, as pathologists, if we get a biopsy from the brain and they have said this is a glioma, first thing I have to identify whether this glioma is of the astrocyte type, oligodendrocyte type, or is it ependymal type. And after that, if I'm confident to say this is from the astrocyte, I have to give a grading, okay? Because the grading system is extremely important for the clinician, because if you see this table, this is the WHO grading system, there are 4 grades, okay? So if you see a tumor which is a grade 1, that is the lowest, it is malignant, but a very low proliferative potential, and it's usually well circumscribed. And the importance here for the clinician is that these tumors may be treated with surgical resection alone. There is a possibility of cure. But grade 2 means microscopically there is cytological atypia. Now, what I want you to remember here is grade 1 tumors look like normal brain. They may look absolutely like normal brain. Yesterday, I was telling you about a condition which is known as gliosis. Gliosis, I said, is the reactive changes which happen in the brain. So the astrocytes, they become hyperplastic and hypertrophic in gliosis. So in that case, when a tumor is a grade 1, it is extremely difficult for us to differentiate between a reactive gliosis and a low-grade glioma. And what comes to our rescue is the radiology and the clinical symptoms of the patient. So as a pathologist, if you give me a bit from a low-grade tumor, I might be able to tell you that this could be a reactive gliosis or this could be a low-grade tumor. Kindly correlate with the clinical symptoms and the radiologic picture. Okay, I cannot outright tell. But if you tell me as a clinician that the patient came to you with a headache or seizures or weakness, okay, and radiologically they say that there is a well-defined mass in the cerebrum, then, and I am very sure that the clinician says that I am very sure that I have given you a bit from the center of the tumor, then as a pathologist, I can say that this is a low-grade glioma, possibly an astrocytoma grade 1. Okay, so that is very important. So the grading system is something which I want you to understand. We will not ask you theory question about grading system, but if you understand this, it gives you a very interesting knowledge about the neuropathology. So the grade 1 tumors have low proliferative potential, they are well circumscribed, and most importantly, they may be cured by surgical resection alone. Grade 2 tumors, microscopically, there is atypia. And they still are low level proliferative, but they become infiltrative. That means they are no longer circumscribed and they can infiltrate. And because they can infiltrate, they can often recur. Because many a times when a neurosurgeon takes out the tumor, in the brain it's extremely difficult. Like if for a general surgeon, if you're dealing with tumors of the leg, you can even chop the whole leg off. But in the brain, you have to see, if you want to clear off the whole tumor, are you actually clearing off areas which are, like maybe the patient came walking to you in the OPD, he's got a tumor, but he came walking to you to the OPD, and then you take out the whole tumor from the brain, but after that you leave the patient in a vegetative state, then that is not acceptable. Okay, so that is why these infiltrative tumors, you try to remove as much as possible without causing damage to the surrounding structures, which might cause the patient to have weakness or paralysis or inability to speak or something to that effect. So that is why CNS tumors, when they are infiltrative, they have the capacity to recur, because you cannot actually clean off the whole tumor in the brain. And those areas can progress to higher grades of malignancy. So as you can see, from grade 1 to grade 2, there's a huge change. And so the survival rate can still be more than 5 years, depending on the grade. Grade 3, apart from atypia, there will be brisk mitotic activity. In this case, surgery is done, but there is always added radiation and chemotherapy, and survival rate is less than 5 years. Now, grade 4 is the most dangerous. Here I'll show you pictures. Apart from cytologic atypia, nuclear atypia, anaplasia, brisk mitosis, there is microvascular proliferation. I'll show you what I mean by this. There will be necrosis. It is cytologically very malignant, and they are necrosis prone, neoplasm. So they have a survival rate which is very, very low. Usually the patients don't survive beyond 3 to 4 months. And surgery is done to relieve the pressure, intracranial pressure, but most of the time the tumor has infiltrated, so you cannot remove all of the tumor. Adjuvant radiation and chemotherapy has to be given, and depending on the amount which has been removed, depending upon the therapy, survival is usually less than 1 year. So I hope you have understood about the WHO grading system. Here I'll show you a picture. This is a normal section of the cerebrum. This is a picture which I showed you in yesterday's class. Okay, so these are the glial cells, which are basically, these large ones are the neurons. Okay, these cells which look like lymphocytes, which have halo around them, I told you yesterday, are the oligodendrocytes. Okay, and this pinkish material, which is the supporting system, is the cytoplasm of the astrocytes. Some of these cells are astrocytes and oligodendrocytes, the microglial cells, all of them, the neurons, they all give cytoplasmic processes which entangle and they form this neuropil in the background. So when you look at this picture, you can see a whole lot of pink. Blue is very less, right? Now you compare with this picture. This picture, you can see that the blue has become more prominent. A lot of pink still, but the number of blue has increased and the individual blues have increased in size and they have become darker. That means that there is increased cellularity, first thing, and there is in the hyperchromasia. And you can see that a little bit, like some are large, some are very tiny, so there is a little bit of pleomorphism. And most importantly, I was telling you that the cytoplasmic processes is usually not seen on H&E in a normal astrocyte. But once you see the cytoplasmic processes, you can see these arrowed ones. You can see that it's got a dark pink cytoplasm with some cytoplasmic processes. If you see this, it means that the astrocytes are reacting. They are becoming hyperplastic and hypertrophy. So in this case, depending on your radiologic image and the clinical symptoms, it could either be a reactive gliosis or it could be a low-grade glioma. We are not seeing much of mitosis and the cells are not so many, not much of anaplasia, so this could be a low-grade glioma. Now look at this picture compared with this. The pink is becoming gradually less because the blues are becoming too much. That means the cellularity is really increased, and you can look at the cells. Some are very big, some are very small, so there's a lot of pleomorphism. Okay, there's a bit of hemorrhage here, so you can see that. And maybe if we go to high power, we can see that mitosis is increased. So this is a higher grade tumor. So this is low grade, this is high grade. Probably this is grade 1 or 2, and this is grade 3 glioma. Now you look at this. You can see that the blue has become much, much more, and the cells, the individual cells, there is so much of variation between the size. There's a lot of pleomorphism, anaplasia has set in, and the blue color is becoming very prominent. That means it's very hyperchromatic. And most important, you can see that kind of these cells seem to be palisading out from this area. This area here, there's not much of blue. That means it's undergone necrosis. Okay, so there is increased cellularity, there is anaplasia, okay, and there is necrosis. This is known as pseudo palisading. And another thing is, you will look for this. This looks like a glomerulus of the kidney. I'm sure it looks like a kidney glomerulus, okay, but this is actually a blood vessel in which the endothelial cells have proliferated so much that they have blocked the lumen of the blood vessel, and these are known as glomeruloid vessels because they resemble the glomerulus of the kidney. Okay, so this is a very important point for us to say that this is a grade 4 tumor. Apart from the increased cellularity, increased anaplasia, pleomorphism, hyperchromatism, there is necrosis here, pseudopalisading, there is microvascular proliferation of glomeruloid vessels. All these are findings which show that they are high-grade tumor. And another thing is, we will look for mitosis. In this case, this is an abnormal mitosis. Okay, so I hope you have understood the role of WHO grading. The main role of WHO grading is for the clinician to be able to prognosticate his case, to be able to to be able to talk to the family and tell them that this is a high-grade tumor, so we don't expect him to live more than 1 year. We will offer these treatment, but however, this is a high-grade tumor and it is infiltrated everywhere. But if you see a low-grade tumor and you see that the circumscription is there, especially on radiology images, then you can give a different picture to the family and say that if we successfully remove this tumor, he might be able to survive much, more than 5 years, and probably it might also be a cure. You have to follow up quite often. Okay. So now when you look at tumors, this is the clinical data which you have to know: the age, the sex, the clinical history, duration of the symptoms, any prior history of cancer, any prior brain surgery, radiation, embolization. Now why we are saying this is because you have to understand as doctors, when you go into internship, you have to fill up the requisition for biopsy. And if you do not give the pathologist a history that there was prior radiation or embolization, then if we see necrosis, we think of a higher grade tumor. But if the patient has undergone embolization or radiation before, the brain tissue may undergo necrosis, not because of the tumor, but because of the therapy. So we cannot give a higher grade tumor in that case. So you have to understand that if you give us the right history, we give you the right diagnosis. That is extremely important. So we have to know all of this information when you give us a biopsy to study. If you give us all this information, you will get the right diagnosis from us. Otherwise, if we see necrosis and we do not have all this history, we might wrongly give a higher grade tumor when actually it was a low grade tumor and the necrosis is due to prior radiation or embolization. Now, imaging data is very, very, very important because why? Brain tumor is not like a tumor of the GIT or tumor of the soft tissue or tumor of the thyroid, in which the surgeon will take out the thyroid and we pathologists hold the thyroid in our hands and we cut the tissue and we see how the tumor is spreading into the organ. Okay, but in the brain, neurosurgeons, they don't open up the brain like in autopsy, and they don't, take out the tumor, scoop it out like they do for other organs. Okay, so the brain, they suck out the tumor little by little. So for pathologists, what we get is tiny bits of tissue. We don't get that huge tumor which we see on radiology. We get tiny bits of tissue. So that is why radiology is very, very important to the pathologist in a neuropathology, because the radiology is the gross pathology for the pathologist. I hope you are following. Okay, so whatever we see, imaging data, the size of the tumor, where the tumor is located, how big is the tumor, is it well circumscribed, is it infiltrating into the surrounding tissue, all this information we will get from radiology, not from the gross specimen which the surgeon gives us, because the gross specimen the surgeon gives us tiny bit of tissue because they suck out the tumor. It's a very different kind of surgery. Okay, so imaging data is important. We have to look into all of these. So another thing is extraaxial means when it is extrinsic to the brain. This is a very important information because as you can see these two pictures, both the tumors are quite well circumscribed. This is a well circumscribed tumor. This is also a well circumscribed tumor. But what you can see here is that this tumor seems to be arising from the dura. This is the dura. I hope you can appreciate this white thing is the dura. And this tumor seems to be arising from the dura and it is compressing into the brain. That means it is extraaxial, meaning it is outside the brain, outside the dura. But because there is no space to grow out because of the skull, it is compressing into the soft brain parenchyma. Okay, so when we see a tumor like this and we see a dural tail, we call this a dural tail, we are very sure that this is an extraaxial tumor and it's probably a tumor arising from the dura. That means it is a meningioma. Okay, but if we see a tumor well within the brain parenchyma, and here also you can see that it is compressing at the third ventricle, these are known as intraaxial. That means they are within the brain. And intraaxial tumors are either astrocytomas or oligodendrogliomas. That means they are glial tumors. Okay, so looking at the radiology, we can actually diagnose whether these tumors are likely to be meningiomas or schwannomas or whether these tumors are likely to be glial tumors. So another important point is supratentorial means above this line, tumors arising supratentorially or tumors arising infratentorially, because tumors of the cerebellum are quite common in children. Okay, so infratentorial tumors arising from the cerebellum are very common in children. And if there are multiple tiny tumors here, that means it's probably metastasis if the person is old. Okay, so we get all sorts of information looking at the location of the tumor and the characteristics of the tumor. So this is a schematic diagram to tell you about the location of the tumor. Location of the tumor is extremely important. So as you can see, this is the brain. When you see a small tumor like this, which is cortical based and quite circumscribed, we will think of a glioma and we will think of a low grade glioma. Okay. But if you see a tumor like this, which is arising right from the cortex and it's coming and you can see that it's infiltrating into the other side cerebrum. Okay. This means it's a highly infiltrative tumor and this area here is necrotic. So when you look at this radiologically, you know you're dealing with a high-grade glioma. Okay, so that is important. This is well circumscribed, it's small, it's not caused much changes, and this is probably a low-grade glioma. If it's very large, there is large areas of necrosis which you can appreciate radiologically, and if it has crossed over and gone to the other cerebrum, this is known as a butterfly glioma because it's got two wings. So these are high-grade gliomas, which is a grade 4 WHO, which is also known as glioblastoma. Okay, so this is important for you to know, low-grade glioma and high-grade glioma. Now, if you see multiple small lesions in the cerebrum or even in the cerebrum or in the cerebellum, and the age group is old, we should immediately think of a metastasis. But if we see a very solid tumor arising in the cerebellum, okay, we should, and it's a child, then our diagnosis will be medulloblastoma. Okay, so basically this picture is meant for you to understand how the location of the tumor, the age of the patient, how the characteristic of the tumor is, how the radiologist actually diagnoses brain tumors looking at the radiology. And like I told you, pathologists, we diagnose the gross pathology is the radiology for us when it comes to brain tumors, because we do not get a specimen like what we see here. Here we might see a nice solid tumor, but when we get it in our pathology lab, we get tiny bits and pieces because the tumor has been sucked out by a pipe. Okay. So these are all radiological images. It can be a CT scan, it can be MRI, and I won't go into details, but basically the tumor may look black in CT scan, and in MRI it may look white. There's a difference between black and white between these two types of investigations. So here again, there's an enhancing mass involving the third ventricle in a child. Okay, so gliomas are tumors of the brain parenchyma. They histologically resemble different types of glial cells. The types are astrocytomas, oligodendrogliomas, and ependymomas. And they have characteristic histologic features. They have distribution within the brain may be different, the age groups are different, and clinical course may be different. So this, we don't ask you fibrillary astrocytomas, but in general, astrocytomas are quite infiltrative tumors. They expand and distort the invaded brain, and depending on the grade of the tumor, astrocytomas may be graded as 1, 2, 3, 4 according to WHO. And if it is a grade 4 astrocytoma, that is known as glioblastoma, the picture which I showed you. It has a very variegated tumor. It's firm to soft. There's a lot of necrosis, cystic degeneration, and hemorrhage. And this is everything which I have told you about the microscopy. We'll repeat it again here. So again here, this is a normal picture. I wish I was in class. I would have asked you all these questions. It's very difficult for me to wait for you to chat. So this is the normal histology. This, I told you, depending on the radiologic image and the clinical features, I might call this a reactive gliosis, or I might call it a low-grade glioma. And when I see something as cellular as this, I know definitely, even if they don't give me the clinical features and radiology, I know that I'm dealing with a tumor here, okay? But I have to look for mitosis, necrosis, anaplasia to confirm whether it's a high grade or a low grade. And if I see a tumor like this, it's definitely a high-grade tumor. There's so much of cellularity, hyperchromasia, anaplasia, necrosis, and these glomeruloid blood vessels and abnormal mitosis. All these point to a WHO grade 4, which is known as a glioblastoma. Okay, so now this I'll wait for you to answer. What do you think this tumor is? You can see this is the cerebrum, and this is the you see this brain, okay, cut section of the brain, and you can see that this tumor is involving both the cerebrum, and it's got a beautiful butterfly shape. So looking at this grossly, you will think of a butterfly glioma. So it is a high-grade glioma, and when you look at it microscopically, again you can see it's highly cellular, anaplastic. This pinkish area here is the necrotic area, and these bluish things look like pseudopalisading, and there is hemorrhage, necrosis, increased cellularity, anaplasia. So what do you think this tumor is? Can you enter the answer in the chat box? What tumor is this? Okay, it's a low-grade glioma or a high-grade glioma. Write that at least. It's a high-grade glioma, very good. Okay. Glioblastoma, very good. So this is a classical example of a glioblastoma. When you have the this butterfly shape. Excuse. Okay. So this is a glioblastoma, and it's a WHO grade 4 tumor. Then look at this picture. You remember I told you about those cells which are like lymphocytes, and on HNE they look like lymphocytes, but they've got a nice clear halo around them. This is an artifact, but it helps us to identify these cells. So I want you to write in the chat box what cells are these and what tumor will contain these cells. You can see this whole section is full of these kind of cells. They look like lymphocytes, but with a halo around them. What cells are these? Very good. They are oligodendrocytes. And what tumor will this be? What tumor will this be called? What glioma will this be called? Oligodendroglioma. Very good. Okay. Now, this tumor we have not spoken about, but this is another glioma. Okay. And what we can see here is there is a blood vessel here. There are RBCs. There is a blood vessel. There is some kind of free space around the blood vessel, and there you can see these cells around it. So this is a perivascular rosettes. When you get perivascular rosettes and these type of cells, this is characteristic of ependymal cells. Okay, so this is a section of oligodendroglioma, and this is ependymoma. Now I want you to look at this picture. This is a normal cerebrum. This is the third ventricle. This is the midbrain. This is the cerebellum. Can you appreciate that in the cerebellum we talk about foliage, leaf-like, right? So you can see the lower part of the cerebellum looks absolutely normal. But look at this. There is loss of that characteristic up here. So there is a tumor here. Okay. So this is a 4-year-old child with a tumor in the cerebellum. And this tumor shows small round cells. They're all small blue cells. Okay. So this tumor arises in children. It's in this location is in the cerebellum. It's highly malignant, but it's radiosensitive. And these are known as medulloblastoma. Okay. So medulloblastoma also can come as a short note for you guys. Glioblastoma, medulloblastoma may come as short notes. Okay. Then the next, meningioma, favorite short note. Okay. So meningioma is a benign tumor which arises from the meninges, particularly from the dura mater. So it is attached to the dura. It arises from the meningothelial cells of the arachnoid. They are very well defined dural base masses. They can compress the underlying brain, but they can be easily separated from it. This is a very, very important point. Meningiomas also have gradings. Just like the WHO, there are grades of meningiomas. Grade 1. And then there is an atypical meningioma, there's anaplastic meningioma, and there is a sarcomatous or a malignant meningioma. But the benign ones are the ones which are well defined, and it is if they arise from the dura, the surgeon can easily pick it up like a ball. If he opens the skull, he can easily pick it up like a ball, because these tumors are firm. They cannot be sucked out like the other gliomas. Okay, so the prognosis, it will be influenced by the size and the location of the tumor, the accessibility to remove it, and the histologic grade. So this is characteristically how meningothelial cells look like. You can see it's arranged in whirling pattern like this. So this is known as a meningothelial whirl. Okay. So this is how meningothelial cells look like. Now look at this picture. You can see that the brain is relatively normal, but there is a tumor here which is arising from the overlying dura. Okay. And radiologically, if you see this on a CT scan, you will say this dura, you will see that this tumor is there, and the dura, tiny bit you'll see on contrast enhanced CT, and you'll see the dural tail, which is characteristically something which the radiologist looks for to tell us that this is a meningioma. Okay, so, and some meningiomas, this is an objective question for you. I think you know that objective questions, samoma bodies are seen in all except So I know that you will know that papillary carcinoma thyroid can show samoma bodies, and serous carcinoma of the endometrium can show samoma bodies, and meningiomas can show samoma bodies. Okay, so this is important for you to know as an objective question. Samoma bodies can be seen in meningiomas. Okay, so we will do skeletal muscle system. We have completed CNS. I will send some assignments for you, some pictorial quiz and also some interpretation of CSF charts, and that will complete our CNS. And the next class, which will be on Friday at 10 o'clock, we will start with the skeletal muscle system. We'll cover everything: skeletal muscle system, peripheral nervous system, the skin tumors, and the soft tissue tumors, which are very, very little. Okay, so we'll cover all of those in the next class. Okay, bye-bye.